Cancer gets the headlines, but cardiovascular disease is the #1 cause of death in the world. It kills more people every year than any other single cause, including cancer. And yet most of us understand it far less well. This series is a plain language tour of heart disease and how it's treated. A quick but important note first: this is educational, not medical advice. If it's about your heart, talk to a real doctor. Today, the foundation: what cardiovascular disease actually is. Let's start with the machine itself, because it's beautifully simple. Your heart is a muscular pump, roughly the size of your fist, and it does one job: it pushes blood through a vast network of vessels. The arteries carry oxygen-rich blood out to every organ, and the veins bring it back. That's it, a pump and a system of pipes, beating about 100,000 times a day, every day, for your whole life. Cardiovascular disease is the umbrella term for anything that damages this pump and pipe system. And while there are many specific conditions, a huge share of them trace back to one underlying process: the slow clogging and stiffening of the arteries. So let's talk about that core process, because if you understand it, you understand most of heart disease. Over years, fatty deposits, cholesterol, inflammatory cells, and debris build up inside the walls of your arteries. This buildup is called plaque, and the process is called atherosclerosis. Slowly, the pipes narrow and stiffen, and less blood gets through. That alone causes problems. But the real danger is sudden: a plaque can rupture, and your body, thinking it's a wound, forms a blood clot right there, which can block the artery completely in seconds. Block an artery feeding the heart, and the heart muscle starts to die. That's a heart attack. Block one feeding the brain, and brain tissue starts to die. That's a stroke. Same process, different address. Here's why cardiovascular disease is such an efficient killer. It's largely silent. The plaque builds up over decades, quietly, with no symptoms at all. Your arteries can be significantly narrowed and you'd never feel a thing. And then, one day, a plaque ruptures, a clot forms, and everything changes in minutes. For a tragic number of people, the very first symptom of their heart disease is the heart attack or the stroke that could kill them. That silence is the whole problem, and it's also why prevention and screening, which we'll cover later, matters so enormously. You can't feel your arteries clogging, but you can measure it, and you can slow it. So what drives this process? A handful of risk factors do most of the damage, and the good news is that most of them are things you can actually change. High blood pressure batters the artery walls and forces the heart to work harder. High LDL cholesterol, the so-called bad cholesterol, is the raw material that builds the plaque. Smoking damages the vessel lining and makes the blood clot more easily. Diabetes and obesity inflame and injure the entire vascular system. And then there are the ones you can't change: getting older, and your family history. Notice how many of these are modifiable. That's the hopeful core of cardiology. This is, to a large degree, a preventable disease. Let's end on the good news, because there's a lot of it. Because we understand the mechanism of heart disease so well: clogged pipes, a strained pump, a faulty electrical system, we've gotten remarkably good at both preventing and treating it. Death rates from heart disease have fallen dramatically over the past few decades, thanks to better drugs, better procedures, and better prevention. A heart attack that would have killed someone 50 years ago is, today, very often survivable and manageable. Over the rest of this series, we'll go through the major conditions one by one: coronary disease, high blood pressure, heart failure, arrhythmias, valve disease, and stroke, and exactly how each is treated. Remember, this is educational, not medical advice. Last episode we saw the heart as a pump connected to a system of pipes. Now let's map the major types of heart disease, because heart disease isn't one thing, and the treatments differ completely depending on which part of the system fails. There's a simple way to organize all of it: think of the heart as having plumbing, electrics, and structure. Almost every condition is a failure of one of those three. Start with the plumbing, because it's the biggest category. Here's a fact that surprises people: the heart is a muscle, and like any muscle it needs its own blood supply. It doesn't get oxygen from the blood sloshing through its chambers. It has its own dedicated little arteries wrapped around its surface, called the coronary arteries. When those coronary arteries clog up with plaque, the heart muscle itself gets starved of oxygen. That's coronary artery disease. It's by far the most common type of heart disease. It's the cause of most heart attacks, and it's the one we'll spend the most time on. When you hear someone had a heart attack, this is almost always the underlying problem. The second plumbing-related problem is what happens when the pump itself weakens. If the heart muscle is damaged, most often by a previous heart attack, or by years of untreated high blood pressure making it work too hard, it can gradually lose its strength. That's heart failure. And the name really is misleading, so let me be clear, heart failure does not mean the heart has stopped. It means the heart is failing to pump strongly enough to meet the body's needs. Blood and fluid back up, so people feel exhausted, short of breath, and their legs and lungs swell with fluid. It's a chronic condition you manage, and modern treatment for it has improved dramatically. We'll give it a full episode. Now the electrics. Your heartbeat isn't random, it's driven by a precise electrical system, a natural pacemaker that sends a signal sweeping across the heart to make it squeeze in the right order. When that electrical system misfires, you get an arrhythmia, the heart beats too fast, too slow, or chaotically out of rhythm. The most common serious one is atrial fibrillation, often called AFib, where the top chambers quiver instead of beating cleanly. AFib matters not just because it feels awful, but because it lets blood pool and clot, and those clots can travel to the brain and cause a stroke. Arrhythmias are a completely different kind of problem from clogged pipes, and they need completely different treatments. The third category is structure. Inside the heart are 4 valves, one-way doors that keep blood flowing in the right direction. Over time a valve can stiffen and narrow, so it won't open properly, or it can start to leak, so blood flows backward. Either way, the heart has to work harder, and eventually it can't keep up. That's valve disease, and it's increasingly fixable, sometimes without open surgery. Finally, remember that the same clogging process from episode 1 happens everywhere, not just in the heart. In the brain's arteries it causes stroke. In the legs it causes peripheral artery disease. So cardiovascular disease really spans the whole body, all connected by that one underlying process. So why bother with this map? Because the category tells you almost everything about the treatment. If it's the plumbing, a clogged artery, you open it up with a stent or bypass it. If it's the pump weakening, you use medicines that take the load off the heart. If it's the electrics, you reset the rhythm with drugs, a controlled shock, or a procedure to fix the faulty wiring. And if it's the structure, you repair or replace the valve. Plumbing, electrics, and structure. Hold on to that framework, because the rest of this series simply walks through each of these in turn, starting next time with the big one, coronary artery disease and heart attacks. This is educational, not medical advice. Before we go condition by condition, let's build the toolkit, because nearly every heart treatment you'll hear about is one of 5 tools, used alone or in combination. The art of cardiology is matching the right tools to the right problem, and knowing when to prevent versus when to rescue. Let's walk through all 5, from the simplest to the most dramatic. The first tool is the one people underrate, so let's be blunt about it. Lifestyle is not the soft, optional alternative to real medicine. It is the foundation that everything else is built on. Not smoking, moving your body regularly, eating well, managing your weight and stress, these measurably lower your blood pressure, lower your cholesterol, and lower your risk, and in early disease they can genuinely turn things around. No drug or procedure works as well if the underlying lifestyle is driving the disease faster than the treatment can fix it. Every good cardiologist starts here, and so does every serious treatment plan. It's the cheapest, most powerful tool in the entire toolkit. The second tool is medicines, and they are the daily workhorses of cardiology. There are a few big families worth knowing. Statins lower cholesterol and, importantly, stabilize existing plaque so it's less likely to rupture. Blood pressure drugs come in several classes that relax the arteries and ease the load on the heart. Blood thinners and antiplatelet drugs, aspirin is the famous one, prevent the clots that actually cause heart attacks and strokes. And there are specialized drugs to steady an irregular rhythm or to support a failing heart. Most people with heart disease end up on a small combination of these, often for life. They're not glamorous, but taken consistently, they prevent an enormous number of heart attacks and deaths. The third tool is mechanical, physically opening a blocked artery. This is one of the true marvels of modern medicine. Doctors thread a thin tube, a catheter, up through a blood vessel, often from the wrist, all the way to the blocked heart artery. They inflate a tiny balloon to crush the plaque and widen the artery, and then leave behind a little metal mesh scaffold, called a stent, to hold it open. The whole thing is called angioplasty, and you're awake for it. During an active heart attack, doing this quickly, reopening the artery before the muscle dies, is exactly what saves lives and limits the damage. This is why speed matters so much when a heart attack strikes. The fourth tool is implantable devices, and these mostly handle the electrical problems. A pacemaker is a small device that watches the heartbeat and gives it a gentle electrical nudge whenever it runs too slow. An implantable defibrillator goes further. It can detect a sudden, life-threatening rhythm and deliver a shock to reset the heart, an automatic rescuer living inside the chest. And the fifth tool is surgery, the heavy artillery for when the others aren't enough. Bypass surgery takes a healthy blood vessel from elsewhere in the body and uses it to reroute blood around the blocked heart arteries entirely. Surgeons can also repair or replace damaged valves. Modern heart surgery is remarkably safe given what it accomplishes, but it's reserved for when the simpler tools can't do the job. The single most useful way to hold this toolkit in your head is to split it into two jobs: preventing and rescuing. Prevention is the daily, unglamorous work, the lifestyle and the medicines that quietly stop the disease from progressing and keep the emergency from ever happening. Rescue is the dramatic stuff, the stents, the shocks, the surgery, for when something acute has already gone wrong. The tragedy of heart disease is that we lean too hard on rescue and not enough on prevention, when prevention is where most of the lives are actually saved. Keep both in mind as we go, because every condition in this series is treated with some mix of these 5 tools. Next up, coronary artery disease and heart attacks. This is educational, not medical advice. This is the big one: coronary artery disease, the most common form of heart disease and the cause of most heart attacks. It's also one of medicine's great success stories. A heart attack that was very often fatal a few decades ago is, today, usually survivable if you get help fast. Let's understand exactly what's happening in a heart attack, and how it's treated in those critical minutes and beyond. Let's build up to the heart attack, because there's often a warning first. When a coronary artery is narrowed by plaque, say it's 70% blocked, the heart can still get enough blood when you're sitting quietly. But the moment you exert yourself, climbing stairs or hurrying, the hard-working muscle demands more blood than the narrowed pipe can deliver. That mismatch causes a squeezing chest pressure or pain, often spreading to the arm or jaw, that eases when you rest. This is angina. It's not a heart attack, the muscle isn't dying yet, but it is a serious warning that the plumbing is failing. Angina is the body asking for help before the emergency, and it's exactly the kind of symptom that should send someone to a doctor. Now the heart attack itself. It happens when one of those plaques suddenly ruptures. The body treats the rupture like an injury and rushes to form a clot, and that clot blocks the artery completely, in seconds. Everything downstream of the blockage is now cut off from oxygen, and heart muscle, starved, begins to die. That's a heart attack, and this is why the classic symptoms, a crushing chest pain or pressure, cold sweat, shortness of breath, nausea, pain spreading to the arm or jaw, are an immediate, call an ambulance emergency. The single most important phrase in all of cardiology is time is muscle. Every minute that artery stays blocked, more of the heart dies and is gone for good. Do not wait to see if it passes. Do not drive yourself. Call for help. So what happens when you get to the hospital in time? The entire goal is simple: reopen that artery as fast as humanly possible, to rescue the muscle that's still alive. The best way is emergency angioplasty, rushing you to the catheter lab, threading a tube up to the blockage, ballooning it open, and placing a stent, often within an hour of arrival. Hospitals drill relentlessly on doing this fast. If a catheter lab isn't quickly available, powerful clot-busting drugs can be given to dissolve the clot chemically instead. And right at the first suspicion, you'll be given aspirin. That humble pill thins the blood just enough to stop the clot from growing while everything else gets moving. Speed here is the whole game. Surviving the heart attack is only half the job, the other half is making sure it never happens again, because a second attack is a real risk. So survivors go home on a bundle of long-term medicines, a statin to drive cholesterol down and stabilize the remaining plaque, blood thinners to prevent new clots, and drugs that lower blood pressure and protect the weakened heart. Cardiac rehab, supervised exercise and lifestyle support, is genuinely one of the most effective things a survivor can do. And for people who turn out to have widespread disease, with many arteries blocked, sometimes the better long-term answer isn't a handful of stents but bypass surgery, rerouting blood around all the blockages at once. Which option is right is a detailed conversation with the cardiology team. The takeaway here could not be more practical. Coronary artery disease is common, it's largely preventable through everything we covered in the toolkit, and a heart attack today is highly survivable, but survival hinges almost entirely on how fast you act. So learn the signs: chest pressure or pain, especially spreading to the arm or jaw, with sweating and shortness of breath. If you or someone near you has them, call emergency services immediately. Do not wait, do not talk yourself out of it. Acting in the first minutes is, very literally, the difference between a full recovery and a devastating one. This is educational, not medical advice, and if you ever suspect a heart attack, call for emergency help right away. High blood pressure, hypertension, is the most common chronic condition on Earth, affecting more than 1 billion people, and it's often called the silent killer for good reason. It causes almost no symptoms, yet it quietly drives heart attacks, strokes, heart failure, and kidney disease. The good news: it's easy to measure and very treatable. Understanding it is one of the highest value things you can do for your health. Let's demystify those two numbers. Blood pressure is simply the force of your blood pushing against the walls of your arteries as it flows. It's written as two numbers, one over the other. The top number is the pressure at the moment your heart beats and pushes blood out. The bottom number is the pressure when your heart relaxes between beats. A reading around 120/80 is healthy. The problem isn't a single high reading. Everyone's rises with stress or exertion. The problem is pressure that stays too high, day and night, for years. That relentless extra force does two things: it slowly damages and stiffens the artery walls, accelerating the plaque process, and it forces the heart to work harder against the resistance, until it starts to wear out. Here's what makes hypertension so insidious. It almost never causes symptoms. You don't feel high blood pressure, no headache, no dizziness, nothing, even when it's dangerously elevated. So people carry it for years, even decades, feeling completely fine, while behind the scenes it's steadily damaging their arteries, their heart, their kidneys, and the tiny vessels in their eyes and brain. And then it presents its bill all at once, as a heart attack, a stroke, heart failure, or kidney failure. That's the silent killer part. It's also why the single most important thing is almost embarrassingly simple: get your blood pressure checked, because you genuinely cannot feel whether it's high. Knowing your number is most of the battle. So how is it treated? It starts, again, with lifestyle, and here lifestyle is genuinely powerful. Cutting back on salt lowers blood pressure directly in a lot of people, because sodium makes the body hold on to water, raising the volume and the pressure. Losing excess weight and exercising regularly both bring the numbers down measurably. Cutting back on alcohol helps, and quitting smoking is essential. For many people caught early with mildly elevated pressure, these changes alone are enough to get them back to a safe range without any medication at all. That's a real and motivating fact. This is a condition where your own choices move the needle, literally. When lifestyle changes aren't enough, and for a lot of people they aren't, especially as we age, the medicines are excellent. There are several well-proven, inexpensive classes, and they work in different ways. Some relax and widen the arteries so blood flows with less resistance. Some help the kidneys flush out excess salt and water, lowering the volume in the system. Others ease the force of the heartbeat itself. Doctors often combine two low-dose drugs from different classes, which works better with fewer side effects than a high dose of one. These medicines are among the most studied in all of medicine. They're generally very safe, and they're usually taken long-term. Taken consistently, they prevent a staggering number of strokes and heart attacks. So the takeaway is beautifully simple, and it's something you can act on today. Because high blood pressure is silent, the entire game is measuring it. Get it checked at a clinic, at a pharmacy machine, or with an inexpensive home monitor, and if it runs high, work with a doctor to bring it down with lifestyle, medication, or both. Controlling blood pressure is, hands down, one of the most effective and best proven ways to prevent a future heart attack, stroke, or heart failure. It's a quiet, unglamorous win, no drama, no emergency, just a number brought under control, and a catastrophe silently avoided. Know your number. This is educational, not medical advice. If high blood pressure batters the arteries, cholesterol is the stuff that actually clogs them. It's the raw material of the plaque we've talked about since episode 1. Cholesterol is also one of the most misunderstood topics in health: good cholesterol, bad cholesterol, eggs, statins, endless confusing headlines. So let's cut through it and explain what actually matters for your heart. First, cholesterol itself isn't evil, your body actually needs it to build cells and make hormones. The issue is how it's carried. Cholesterol can't dissolve in blood, so it travels in little protein packages called lipoproteins, and two of them matter. LDL delivers cholesterol out to the tissues, and when there's too much of it, the excess gets deposited into the artery walls. That's the raw material of plaque. So LDL earned its nickname, the bad cholesterol. HDL does the reverse, it scavenges cholesterol from the arteries and carries it back to the liver for disposal. That's the good cholesterol. The simplest mental model: LDL drops cholesterol off in your arteries, HDL cleans it up. You want LDL low and HDL healthy. So here's how the plaque actually builds, because it's more than just grease in a pipe. When there's too much LDL cholesterol circulating, it works its way into the artery wall and gets chemically damaged there. Your immune system sees that damaged cholesterol as a threat and sends in cells to clean it up, but they get overwhelmed and stuck, and the whole area becomes inflamed. Over years, this festering mix of cholesterol, immune cells, and scar tissue grows into a plaque. That's atherosclerosis. And it's worth repeating that this one process, driven substantially by LDL, is the root cause behind heart attacks, the majority of strokes, and the artery disease that threatens people's legs. Lower the LDL, and you starve the whole process of its raw material. That brings us to statins, the cornerstone of treatment and one of the most important drug classes ever developed. Statins work by reducing how much cholesterol your liver produces, which pulls your LDL down substantially. But here's the underrated part: they do more than just lower a number. They calm the inflammation in the artery wall and they stabilize existing plaques, making them far less likely to rupture and cause that sudden clot. Statins are among the most rigorously studied drugs in all of medicine, tested in enormous trials, and in people at higher risk they clearly and substantially cut the rate of heart attacks and strokes. They've been genuinely misrepresented online. For the people who need them, the evidence that they save lives is about as strong as evidence gets in medicine. For people who need even more LDL lowering than a statin gives, those at very high risk, or with stubbornly high genetic cholesterol, there's now a whole toolkit beyond statins. Ezetimibe is a pill that blocks the gut from absorbing cholesterol from food. And a newer class, called PCSK9 inhibitors, are injectable drugs that can slash LDL dramatically, to levels we couldn't reach before. On diet, yes, it matters, especially cutting back on saturated fat, but here's an honest truth that surprises people. For someone at genuine cardiovascular risk, diet alone usually moves LDL only modestly, and the medication does most of the heavy lifting. Diet supports the treatment, it rarely replaces it. Both together is the winning combination. So the practical takeaway mirrors the last episode: know your numbers. A simple, cheap blood test reveals your cholesterol, and LDL is the one that most directly drives your risk. If it's high, lowering it, through diet and exercise, and through a statin when your overall risk warrants it, is one of the best proven ways in all of medicine to prevent a future heart attack or stroke. Don't let the online noise about cholesterol confuse you into inaction. Talk to a doctor about your actual numbers and your actual risk. Between knowing your blood pressure and knowing your LDL, you've now got the two most important measurements in preventive cardiology. This is educational, not medical advice. Heart failure is one of the most common reasons older adults end up in the hospital, and one of the most misunderstood diagnoses there is. The name sounds like the heart has stopped, but it hasn't. Heart failure means the pump is struggling to keep up with the body's demands. It's a chronic condition you manage, and in the last few years the treatment for it has been quietly transformed. Let's understand it. So let's define it properly. Heart failure means the heart can no longer pump enough blood to meet the body's needs, not that it has stopped, but that it's failing to keep up. It's almost always the end result of some other damage that came first: a previous heart attack that scarred the muscle, years of high blood pressure forcing the heart to overwork, or a leaky or narrowed valve. When the pump falls behind, blood backs up behind it, and the pressure pushes fluid out of the vessels and into the tissues. That fluid is what causes the hallmark symptoms, breathlessness, especially lying down, as fluid collects in the lungs, and swollen, heavy legs and ankles. People also feel profoundly tired, because their muscles aren't getting the blood they need. There are actually two main flavors of heart failure, and the difference matters for treatment. Doctors measure something called the ejection fraction, basically, the percentage of blood the main chamber squeezes out with each beat. In the first type, that fraction is reduced, the muscle is weakened and simply can't squeeze hard enough, often after a heart attack. In the second type, the ejection fraction is preserved, the squeeze looks normal, but the muscle has become stiff and thick, so it can't relax and fill properly between beats. The two can look almost identical from the outside, same breathlessness and swelling, but they behave differently and respond to different treatments. This is exactly why getting the right tests, like an ultrasound of the heart, matters so much. Now the good news, because treatment for the weaker type of heart failure has genuinely been revolutionized. Modern care rests on what cardiologists call the 4 pillars, 4 kinds of medicine that, used together, dramatically improve survival and keep people out of the hospital. The first relaxes the arteries and blocks the harmful stress hormones that otherwise drive the heart into the ground. The second, beta blockers, slow the heart and protect it over the long haul. The third helps the body flush out the excess salt and water, relieving that fluid buildup and breathlessness. And the fourth is a real surprise, a class called SGLT2 inhibitors, originally invented as diabetes drugs, which turned out to help failing hearts so much they're now a cornerstone of treatment. 4 pillars, working together, that combination has rewritten the outlook for this disease. Beyond medicines, devices help certain patients. Some people with heart failure have a heart that beats out of sync, the walls no longer squeezing together, and a special pacemaker can resynchronize it, coordinating the beat so the pump works efficiently again. Because a weakened heart is also prone to dangerous rhythms, many patients get an implantable defibrillator as an insurance policy against sudden cardiac arrest. And for the most severe, end-stage cases, there are last resorts that are genuinely remarkable, a mechanical pump, called an LVAD, that can be implanted to help the heart push blood, and, ultimately, heart transplantation. Those are for the small minority who need them, but they exist, and they save lives that once couldn't be saved. The takeaway is that heart failure is serious and chronic, but it is not the death sentence the name suggests, and it's far more manageable today than even a decade ago. With the 4 pillars of modern therapy, plus devices where needed, many people live active, meaningful years and stay out of the hospital. And patients themselves have real power here, weighing yourself daily to catch fluid buildup early, watching your salt and fluid intake, and taking those 4 medicines faithfully genuinely keeps people well and out of the emergency room. It's a partnership between good medicine and daily self-care. If you or someone you love has this diagnosis, know that the modern outlook is far more hopeful than the word failure implies. This is educational, not medical advice. So far we've focused on the plumbing, the arteries and the pump. This episode is about the electrics. Your heart runs on its own electrical system, and when that system misfires, you get an arrhythmia, a heartbeat that's too fast, too slow, or chaotically irregular. The most common serious one, atrial fibrillation, is becoming more common as populations age, and it's a leading, preventable cause of stroke. Let's understand it. To understand arrhythmias, picture the heart's wiring. Every single heartbeat begins with a tiny electrical spark from a patch of specialized cells, the heart's own natural pacemaker, up in the top chamber. That spark sweeps across the heart in a precise, timed sequence, telling the top chambers to squeeze first, then the bottom chambers, so blood moves through in the right order. It's an elegant electrical relay, firing 60 to 100 times a minute, your whole life. An arrhythmia is any disruption of that orderly signal. Note that this is a completely different kind of problem from clogged arteries, the pipes might be perfectly clear, but the electrical timing has gone wrong. So it needs an entirely different set of treatments. The most important arrhythmia to know is atrial fibrillation, or AFib. In AFib, the electrical signal in the top chambers of the heart descends into chaos. Instead of beating cleanly, those chambers just quiver, and the whole heartbeat becomes fast and irregular, that classic irregularly irregular pulse. Some people feel it intensely, a racing, fluttering, pounding heart, breathlessness, dizziness, or deep fatigue. But here's the catch, other people feel absolutely nothing, and have no idea they're in AFib at all. That silence is dangerous, and to see why, we need to talk about the real reason AFib matters. It's not usually the irregular beat itself that harms you. It's what that quivering does to the blood. Here's the crucial link. When the top chambers of the heart quiver instead of squeezing properly, blood doesn't get pushed through cleanly, it stagnates and pools in a little pouch of the heart. And pooled, still blood tends to clot. If one of those clots breaks loose, it gets pumped straight up toward the brain, where it can lodge and block an artery, causing a stroke. This is why atrial fibrillation is one of the leading causes of stroke, and why those strokes are often severe. So, counterintuitively, the very first treatment priority in AFib is frequently not fixing the rhythm at all, it's preventing that clot with a blood thinner. Protecting the brain comes first. Reliable blood thinners for exactly this are one of the quiet success stories of modern cardiology. Beyond the blood thinner, treating the arrhythmia itself follows a few paths. One approach is rate control. Don't worry about the chaos up top, just use medicines to slow the overall heartbeat down to a comfortable, safe range, and many people feel fine that way. The other approach is rhythm control, actually restore the normal beat, either with antiarrhythmic drugs or with a brief, controlled electric shock to the chest, under sedation, that resets the heart like rebooting a computer. And then there's the more definitive option, ablation. A cardiologist threads a catheter up into the heart and precisely cauterizes the small patches of tissue that are generating the faulty electrical signals, essentially editing the wiring. For many people, ablation can dramatically reduce or even eliminate their AFib. And for slow rhythms, the opposite problem, a pacemaker keeps the beat from dropping too low. The practical takeaway has a modern twist. Because atrial fibrillation can be completely silent, catching it is half the battle, and technology is genuinely helping here. Modern smartwatches and fitness trackers can now detect an irregular heart rhythm and prompt the wearer to get it checked by a doctor, and they've caught real, dangerous AFib in people who had no idea. If your watch flags an irregular rhythm, don't panic, but do take it to a professional to confirm. The bottom line is hopeful. Atrial fibrillation is common and it's a serious stroke risk, but once it's found, that risk can be dramatically reduced with treatment. Knowing your own pulse, and paying attention when something feels off, genuinely matters. This is educational, not medical advice. This episode is about structure, specifically, the heart's valves. Your heart has 4 valves that act as one-way doors, keeping blood moving in the right direction. When a valve wears out, either stiffening shut or leaking backward, the heart has to work harder, and eventually it struggles. The exciting part, fixing valves used to always mean open heart surgery, and increasingly it doesn't. Let's look at how this field has been transformed. Let's start with what these valves actually do, because it's wonderfully mechanical. Blood has to flow through the heart's 4 chambers in one direction only, never backward. To enforce that, there are 4 valves, positioned between the chambers and at the exits, and each one works like a one-way door. It swings open to let blood through when the heart squeezes, and then snaps firmly shut to stop that blood from sloshing back the wrong way. In fact, that familiar lube-dub sound of a heartbeat is the sound of those valves snapping closed. When they're working, you never think about them. The trouble starts when a valve, after decades of opening and closing billions of times, begins to wear out. A valve can fail in 2 opposite ways, and it's worth knowing both. The first is stenosis, which means narrowing. The valve stiffens, often from calcium building up on it with age, and it can no longer open all the way. Now the heart has to strain hard to force blood through a tight, restricted opening, like breathing through a straw. The most common and serious example is aortic stenosis, the narrowing of the main outflow valve, which tends to show up in older adults. The second way is regurgitation, which means leaking. Here the valve doesn't seal properly when it closes, so with every beat some blood squirts backward the wrong way. The heart ends up having to pump the same blood twice, and that inefficiency slowly exhausts it. Stenosis is too tight, regurgitation is too loose. How do valve problems show up? Often slowly and sneakily. As a failing valve makes the heart work harder, people feel breathless when they exert themselves, unusually tired, dizzy or lightheaded, or they notice chest tightness. Because these creep in gradually and often affect older adults, they're frequently written off as just getting old or being out of shape, which is a shame, because these are treatable. The classic clue is a heart murmur, the sound of turbulent blood flowing through a faulty valve, which a doctor can hear through a stethoscope. From there, the key test is an echocardiogram, an ultrasound of the heart, which lets doctors watch the valves moving in real time and measure exactly which one is failing and how severely. That picture decides whether and when to intervene. Now the genuinely exciting part. For decades, fixing a bad valve meant open heart surgery, opening the chest, stopping the heart, and repairing the valve or swapping it for an artificial one, either a durable mechanical valve or one made from treated animal tissue. That surgery works well and is still right for many people. But it's a big operation, and plenty of frail, older patients were simply too high risk to survive it, so they went untreated. That changed dramatically with a procedure called TAVR. Instead of opening the chest, doctors thread a brand new valve, collapsed inside a catheter, up through an artery in the leg, position it inside the old failing valve, and expand it into place, while the heart keeps beating. The patient is often home in a day or two. For aortic stenosis especially, this has been a revolution, offering a fix to millions who previously had no safe option. The takeaway is a hopeful and practical one. Heart valve disease becomes more common as we age, and it is very fixable, but only if someone finds it. So the lesson is, don't automatically dismiss creeping breathlessness, fatigue, or dizziness in yourself or an older relative as just aging. Those can be the signs of a failing valve, and a simple stethoscope check followed by an ultrasound can catch it. And the fixes keep getting gentler. What once demanded major open heart surgery can now, for many people, be done through a catheter in the leg. If a valve problem is on the table, it's worth asking which approach fits. Getting evaluated is what turns a slowly failing heart into a fixed one. This is educational, not medical advice. A stroke is, in a very real sense, a heart attack that happens in the brain, the same clogged artery process from episode 1, striking a different organ. Stroke is a leading cause of death and the top cause of long-term disability worldwide. But like heart attacks, strokes are now often treatable if you act fast enough, and much of the damage is preventable. This is one of the most important episodes to really take in. There are two fundamentally different kinds of stroke, and telling them apart is critical because the treatments are opposite. The most common, about 85%, is the ischemic stroke, and it's exactly like a heart attack. A clot blocks an artery supplying the brain, and the brain tissue downstream, suddenly cut off from oxygen, begins to die. The other kind is the hemorrhagic stroke, where a blood vessel in the brain actually bursts and bleeds into or around the brain. Both are dire emergencies, but here's why the distinction matters so much. For a clot, you want to thin the blood and bust the clot, but doing that to someone who's bleeding would be catastrophic. So the very first job at the hospital is an urgent brain scan to tell which type it is, before any treatment. Because a stroke is a race against time, everyone should know how to spot one, and there's a simple memory aid: think fast. F is for face, ask the person to smile, and look for one side drooping. A is for arms, ask them to raise both arms, and watch for one drifting down. S is for speech, listen for slurred or garbled or strange speech. And T is for time, if you see any of these, it's time to call emergency services immediately. The reason people delay is that a stroke is usually painless, there's no crushing pain to scream emergency, just a face that won't move or words that won't come. But make no mistake, with stroke, just like heart attack, lost time is lost brain. Roughly 2 million brain cells die every minute a stroke goes untreated. Fast, and call for help. For the common, clot-caused stroke, the treatment mirrors the heart attack: reopen that artery as fast as possible to rescue the brain tissue that's still alive. There are two main ways. The first is clot-busting drugs, given through a vein to chemically dissolve the clot, but they only work, and are only safe, within a few hours of the first symptoms, which is exactly why speed is everything. The second is one of the most dramatic advances in modern medicine: thrombectomy. For a large clot, a specialist threads a catheter up through an artery, all the way into the brain, and physically grabs and pulls the clot out, literally removing the blockage. Patients who were paralyzed can sometimes recover function on the table. But again, all of this depends on arriving fast enough. The treatments are miraculous, the window is narrow. Now here's the empowering part: most strokes are preventable, because preventing stroke is just preventing the disease this whole series has been about. Controlling blood pressure is the single biggest lever. High blood pressure is the #1 cause of stroke. Lowering cholesterol helps, not smoking helps, and treating atrial fibrillation from the last episode with a blood thinner is crucial. since those pooled clots are a major stroke source. It's the same prevention playbook, protecting the brain instead of the heart. And remember, this clogging process affects the whole body. When it narrows the arteries in the legs, it causes peripheral artery disease, leg pain when walking, which is itself a red flag that the arteries everywhere, including to the heart and brain, are in trouble. It's all one connected system. So the takeaway is two-sided, and both sides save lives. First, recognition: memorize fast, face, arms, speech, time, and the instant you see those signs in anyone, call emergency services without hesitation. Modern stroke treatment can be genuinely astonishing, reversing what looked like permanent damage, but only if the person reaches the hospital inside that narrow window. Do not wait to see if it improves. Second, prevention: the strokes you never have are the ones you win biggest, and you prevent them with the very same blood pressure control, cholesterol management, and AFib treatment that protects your heart. Your brain and your heart are protected by the same habits. Learn fast, share it, and control your risk factors. This is educational, not medical advice, and if you ever suspect a stroke, call for emergency help immediately. Everything we've covered has led here, because the best treated heart attack is the one you never have. This episode is about prevention, how to know your actual risk, what to screen for, and what genuinely moves the needle versus what's just noise. If you take one episode of this series to heart, so to speak, make it this one. Preventing cardiovascular disease is one of the most achievable wins in all of medicine. Prevention starts with knowing where you stand, and that comes down to a handful of numbers. 4 of them capture most of your controllable risk. Your blood pressure, from episode 5. Your LDL cholesterol, from episode 6. Your blood sugar, which flags diabetes, a powerful accelerator of heart disease. And your body weight, often tracked as waist size. Here's the theme that ties this whole series together: not one of these can be felt. You cannot sense high blood pressure, high cholesterol, or rising blood sugar; they're all silent. So they have to be measured, with a cuff and a simple blood test. Knowing these 4 numbers is the absolute foundation of protecting your heart, and most people can get all of them at a single checkup. Individual numbers matter, but what doctors really care about is your overall risk, because the numbers interact. So they use risk calculators that combine everything: your blood pressure, your cholesterol, your age, your sex, whether you smoke, whether you have diabetes, your family history, into a single estimate, roughly your percentage chance of having a heart attack or stroke in the next 10 years. That combined score is far more useful than obsessing over any one value, and it's what guides the big decisions. For example, whether you should start taking a statin isn't decided by your cholesterol alone, it's decided by your total risk. 2 people with the same cholesterol might get completely different advice depending on everything else. If you're over 40, asking your doctor to run your risk score is a genuinely valuable conversation. So what actually works? Let's separate the signal from the endless noise. Not smoking is number 1. If you smoke, quitting is the single most powerful thing you can do for your heart, full stop, and the benefits start within weeks. Moving your body most days matters enormously, and it doesn't require a gym. Brisk walking counts, and even modest activity meaningfully lowers risk. Eating mostly whole foods and plants, with less salt and less ultra-processed food, the Mediterranean-style pattern has the best evidence. Keeping your blood pressure, cholesterol, and blood sugar controlled, using medication when your risk warrants it. And the underrated 2, getting enough good sleep, and managing chronic stress, both of which genuinely affect heart health. Notice these are mostly ordinary, boring, daily habits. That's exactly why they work, and why consistency beats intensity. Beyond the basic numbers, there's one screening test worth knowing about, because it can settle uncertain cases. It's called a coronary calcium scan, a quick, low-dose CT scan of the heart that literally measures the amount of calcified plaque built up in your coronary arteries. Think about how useful that is. Instead of just estimating your risk from statistics, it takes an actual look inside your arteries and gives you a score. A score of 0 is genuinely reassuring. A high score is a wake-up call that plaque is already there, even if you feel perfectly fine. It's especially valuable for people in that uncertain middle zone, where it's not obvious whether to start aggressive treatment. The scan can turn a murky maybe into a clear decision. It's not for everyone, but it's a conversation worth having with your doctor if your risk is unclear. So the big picture takeaway of this whole series lands right here. The number one killer in the world is, to a remarkable degree, preventable. Not entirely, genetics and bad luck are real, but far more than most people realize. You prevent it with numbers you can actually know and habits you can actually control, started early and kept up consistently. There's no secret, no miracle supplement, no biohack, just the unglamorous, genuinely powerful basics, done steadily, in partnership with a doctor who knows your risk. For most people, taking care of your cardiovascular health is quite literally the highest return health investment available. It's not too late to start, and it's rarely too early. This is educational, not medical advice. We'll close the series by looking ahead. Cardiology has been one of medicine's great success stories, and the next decade may be its most exciting yet, driven by artificial intelligence, wearable sensors, and a new generation of drugs. Let's look at what's coming, and how it might change heart care from something that reacts to emergencies into something that quietly prevents them. And this ties right back to what this channel is really about. Start with artificial intelligence, because it's already arriving. An ECG, that simple recording of the heart's electrical signals, turns out to contain far more information than the human eye can extract. AI models trained on millions of ECGs can now spot subtle patterns that flag hidden problems, and remarkably, they can sometimes predict a person's future risk of conditions like atrial fibrillation from a tracing that looks completely normal to a cardiologist. AI is also getting expert level at reading heart ultrasounds and CT scans, measuring things faster and more consistently than humans. The promise here isn't replacing the cardiologist, it's giving every clinic, everywhere, access to expert-level interpretation, and catching disease earlier than we ever could before. This is exactly the kind of AI in medicine this channel explores. The second shift is the one already on millions of wrists. For all of history, we measured the heart in rare snapshots, a reading at a checkup, an ECG during a symptom. Wearables are changing that completely. Smartwatches already detect atrial fibrillation and have sent countless people to the doctor with a problem they never felt. They track heart rate, activity, and sleep continuously, and the next generation is pushing toward cuffless blood pressure and even more. Think about what continuous monitoring means. Instead of hoping to catch a fleeting arrhythmia during a 5-minute test, the device watches around the clock, in real life. The heart is becoming, for the first time, something we can monitor continuously rather than occasionally. That turns medicine from reactive to genuinely proactive. Third, the drugs keep getting better. On cholesterol, newer treatments can lower LDL with an injection given just a few times a year instead of a daily pill, a huge help for actually sticking with treatment. And one of the biggest cardiology stories of the decade comes from an unexpected place. The GLP-1 drugs, the ones famous for weight loss and diabetes, have now been shown in major trials to significantly reduce heart attacks and strokes. That's reshaping how we think about treating obesity as heart protection, and it connects directly to the metabolic medicine we'll cover in a future series. Further out, gene-based therapies are in trials that aim to switch off the genes driving dangerously high cholesterol permanently, potentially a one-time treatment for a lifelong problem. The pipeline is genuinely thrilling. Now put all three together, because the combination is where it gets genuinely transformative. Imagine artificial intelligence that predicts your risk years in advance, wearable sensors that monitor your heart continuously in daily life, and safe, powerful drugs that lower that risk before anything ever goes wrong. That's the future taking shape, a shift from a cardiology that reacts to heart attacks in the emergency room, to one that quietly prevents them years earlier, woven into everyday life. Instead of the first sign of heart disease being a heart attack, the first sign becomes a gentle nudge from your data, long before any damage is done. That's the dream this whole field is now chasing, and a lot of it is being built with the AI tools this channel is all about. It's a genuinely hopeful direction. So here's the series in one closing thought. The future of cardiology is earlier, continuous, and increasingly preventive, powered by AI, wearables, and remarkable new drugs, and it's genuinely exciting. But notice that all of it serves the same fundamentals we've spent this series on. Know your numbers. Protect your arteries by controlling blood pressure and cholesterol. Don't smoke, keep moving, eat well. Recognize the signs of a heart attack and a stroke, and act fast. Those basics, done consistently, are still how the vast majority of people beat the world's #1 killer, and the technology is simply going to make them easier and more powerful. Thank you for watching this series on understanding heart disease. Take care of that remarkable pump. And as always, this is educational, not medical advice.